Now we'll be talking about a very interesting drug that is heparin. Heparin is universal and heparin is extensively used in ICU setting, especially for all those patients who have some cardiac issues. Now we must know that heparin is an anticoagulant drug, so it affect coagulation. Antiplatelet is different and anticoagulant is different. Antiplatelets act on platelets, whereas anticoagulant they act on coagulatory system. We must know that the molecular weight of this heparin is around 10,000 to 20,000 molecular weight is there, whereas Glixane or the low molecular weight heparin, they have molecular weight of 5,000 or 10,000 weight. That is the reason why we call it as low molecular weight. And this is not low molecular weight, this is standard molecular weight heparin, or we call it as unfractionized heparin because this is not fractionated. We must know that this is a strong organic acid in the body and it carries electronegative charge. Now, what is interesting is it has anticoagulant properties as it activates antithrombin 3, and this antithrombin 3 is naturally present in the body, which inactivates all the clotting factors which are activated, especially factor 10, factor 2, factor 9, factor 11, factor 12, and factor 13 as well. So, in short, mainly it inhibits this factor 10 and factor 2, and these are the main component of intrinsic as well as extrinsic pathway of coagulation. That is the reason why coagulation is inhibited, clot formation is inhibited. We must know that this factor 2, actually factor 2, which is called thrombin, is the responsible thing which convert this fibrinogen into fibrin. As this thrombin is inhibited, this conversion of fibrinogen into fibrin is inhibited, and fibrin is the main component of the clot because this clot is made up of all this fibrin which with platelets, RBCs, neutrophils, and all the other components in it. So in heparin in low dose, it doesn't prolong prothrombin time, but it definitely prolongs APDT. Thus, these activated partial thromboplastin time. That is the reason why for monitoring we always use APTT. So in low dose, heparin selectively inhibits intrinsic pathway, whereas at higher dose it inhibits both intrinsic and extrinsic pathway as well. So in higher concentration of heparin, whenever it is given, the intrinsic pathway will be prolonged or will be affected as well as extrinsic pathway will be affected. So this PT, that is prothrombin time, will get delayed or it will be affected in heparin, whereas it doesn't get affected with Glixane or low molecular weight heparin much. We must know that heparin also has some antiplatelet activity as well in when given in higher dose, and it inhibits platelet aggregation and it prolongs bleeding time, which may also help for prevention of clot, or it may also exert an antiplatelet property. When this heparin is given by subcutaneous route, the anticoagulant effect develops around 60 minutes after. As it does not cross blood-brain barrier and placenta, this is the anticoagulation of choice during pregnancy and it can be used in pregnancy. And after metabolization of this heparin, the fragments of heparin are excreted in the urine. This could be the reason that one of the most common mm, problem, which is bleeding, usually always is in as a form of hematuria. So hematuria is one of the earliest sign of bleeding because of the heparin, which is very reversible. We can simply stop or reduce the dosage of heparin, and usually the bleeding improves or hematuria improves over a period of few hours to a day. So whenever this IV injection of 100 unit per kg is given, the half-life usually remains around 1 hour. But whenever we increase the dose beyond this 100 unit per kg, then the half-life is prolonged from 1 hour to up to 4 hours. So the half-life of this drug is longer, not only when used in higher dose, but also in cirrhotics and kidney failure patients because this metabolism of heparin involves liver as well as the excretion is through kidney. And we must know that as there is extensive clot burden in pulmonary embolism, the heparin has a shorter duration of action or shorter half-life in pulmonary embolism. So more heparin or higher dose of heparin can be required in pulmonary embolism. We must know the adverse effect. As I told, bleeding is the most common problem with the heparin, and almost always the first sign is hematuria, which could be very commonly reversible. We have to stop heparin for a few hours, maybe a day, and the hematuria can markedly improve, particularly if it is gross. The bleeding can occur at anywhere. It can be gastrointestinal, intracranial, or anywhere in the body. It can be retroperitoneal, or into the spinal cord, anywhere in the body. Thrombocytopenia is one of the uncommon side effects, but it is very well known associated. Usually it is mild and transient, and it is due to aggregation of platelets. When do we use heparin? Now this is very important question. Any SES, that is acute coronary syndrome, which may involve ST elevation MI, non-ST elevation MI, or unstable angina, heparin is one of the most important drug. It is also used to prevent the stent thrombosis. That is the reason why heparin in all this uh, in STEMI or NSTEMI or unstable angina, it is used in the dosage of usually 5,000 unit per 6 hourly, means around 3 to 4 times per day, 4 times per day, depending on weight of the patient. Uh, and this is usually continued till patient is hospitalized, usually for 5 to 7 days. At the time of discharge, usually heparin is discontinued, and most of the time the patient is already on dual antiplatelet. For arterial thrombosis, which may involve radial artery, popliteal artery, ulnar artery, and if the patient is having gangrene, then uh, catheter guided thrombolysis is definitely one option, but apart from that, and along with that, heparin is still continued for 48 to 72 hours till the perfusion of the particular extremity is good. Once the perfusion is established, once the flow is established, then the heparin infusion is discontinued and the patient is shifted on fixed dose low molecular weight heparin or fixed dose heparin dosage 4 times a day, depending on the weight of the patient. For massive P, definitely, as I told, there is shorter half-life of the heparin, so heparin gets used up very fast. So very commonly 7,000 to 10,000 unit of injection heparin is given bolus, and which is followed by 1,000 to 1,250 units per hour IV infusion for at least 2 to 3 days or till the patient is stabilized. Catheter-guided thrombolysis is one of the very potential option because catheter-guided thrombolysis usually requires only 10% of the thrombolytic dose compared to the normal dosing. And we call it as massive whenever there is a patient has hypotension or a reduced perfusion or if the patient is unstable. We label that patient as the patient has massive pulmonary embolism. So till stabilization, the heparin infusion is continued. Once the patient is stable, the infusion of heparin is changed to fixed dose heparin to 5,000 unit 4 times a day, or maybe in the low molecular weight heparin, that is glyxane, enoxaparin, or fondaparinux, depending on the choice. For massive PA, we definitely monitor whenever the patient is on heparin infusion. We always monitor APDT, and the target of APDT is around 2 to 2.5 times the normal. Usually, the normal APDT range is 30, whereas what we target is around 60 to 75. Whenever there is a surgical insult to the hand, whenever there is crush injury, so whenever there is a reconstruction of hand or extremity, because of extensive crush injuries of the small vessels, the chances of clotting in this reconstructed artery arteries or arterioles is much more because of the crush injury. So to keep these smaller arteries, arterioles patent, very commonly heparin is continued at the rate of 750 to 1000 units per hour for around 3 days to prevent the clotting of repaired reconstructed microcirculation and to prevent the gangrene. So this was all about heparin. Today we'll again meet. Thank you.